everyone. My name is Nehal Desai. I'm going to do a quick presentation on the endocrinology section of our pharmacy concept review. Um, these are just some little things that I feel might be important um, when reviewing topics pertaining to this section of pharmacy. So, Um, basically, take a look at some of the pancreas terminology, the alpha and beta cells, understand their differences, how it works mechanistically with the medications that are used. Also, look at the other organs as well as they play a major role in some of the endocrinology fundamentals in terms of drug interaction and its mechanisms. Um, Look at the thyroid mechanism as well. Also, some of those thyroid medications are prodrugs or prodrug like things. So, definitely take a look at that. In terms of bones, look at osteocyte, osteoclast, osteoblast activity, and also look at the reproductive pathway as well. There are some medications there as well, especially when you're dealing with things like estrogen, progesterone, ovulation, ovaries, and all of that. So let's dig into some of the practice questions here. So the first one is regarding like a diabetes question. It's a 58-year-old patient with type 2 diabetes and established cardiovascular disease requires additional glycemic control. Which medications demonstrate cardiovascular benefit? Um, so there's four choices here. You got glyburide, pioglitazone, empagliflozin, or acarbose. Um, just knowing that you should actually understand what the classes are of these medications. Glyburide is essentially one of the sulfonylureas, and specifically how these work. So glyburide is one that when it binds to this SER1 receptor um, or the potassium ATP channel, it's going to keep the potassium inside the cell, depolarizing the beta cell of the pancreas, and then it's going to secrete insulin from there um, by releasing calcium. So that's just the basics of the mechanism of how you can see it working. Pioglitazone, they can work in like the liver, the fats, the muscle. Um, Essentially, they just go into the cell and program the um, DNA to make the those parts more sensitive, insulin, increasing the insulin sensitivity. And then the empagliflozin mainly works in the kidney area, specifically in the proximal convolute tubule, where it will prevent or inhibit the SGLT2 transporter so that the glucose doesn't get reabsorbed back into the blood. It gets excreted out through urine. Then you have find the acarbose, which is um, specifically used around the small intestine. At the brush border, you can see um, there is an enzyme that will actually break down the um, carbohydrates so that it can be small enough for it to be reabsorbed back, for the glucose to get reabsorbed back in your bloodstream. So essentially, this will actually inhibit the breakdown of carb and then find it excreted. So these are just some of the ways this medication works. However, the one that has demonstrated cardiovascular benefit is going to be empagliflozin. So just wanted to um, show you a little bit about these. Then the next one regards is talking about the insulins. Patient takes rapid-acting insulin before meals. Which insulin has the fastest onset of action? Um, in this case, you have to look at the timings of these insulins. The long-acting ones like insulin detamir and I'm sorry, not Lispro. Um, this is actually incorrect, so give me 1 second. Let me fix that here. Okay. So insulin glargine has essentially longer duration. So it's going to be a longer onset as well. So is the detamir. And Lispro is going to be the short duration. So its onset of action is going to be around 10, roughly like maybe 10 minutes, 10 to 15 minutes. And when I mean long duration, you're talking about like longer time during the day. NPH is a little bit long duration, but it's an intermediate. And this one is typically between like 12 to 24 hours or somewhere around that range, or just like the long durations, which is roughly around 24 hours. It's important to understand the timings of the insulins, and understanding which brand generic names are long acting versus short acting in terms of the insulin and its pharmacology. So in this case, if you're talking about a rapid acting insulin, the answer to this one would be the insulin Lispro. The next one here is regarding a thyroid section of endocrinology. A patient with primary hypothyroidism is started on replacement therapy. So which medication is considered first-line treatment? And so there's different types of thyroid medications. I'm going to tell you now, the main ones when your thyroid is low are definitely going to deal with the Leo and levothyroxine. So leothyronine and levothyroxine. The other two choices, which is methimazole, propylthiouracil, are going to essentially deal with when there is too much basically when you're hyperthyroid. So when there's too much thyroid, that's where you would take these two. When your thyroid is really low, then you would take the leothyronine or levothyroxine. If you had to pick on exam the first line treatment, it would usually be the levothyroxine. Levothyroxine is going to be broken down from T4 to T3. Now, T4 and T3 are both the thyroid hormones. Now, how it gets broken down is by an enzyme called 5' deiodinase, and that one breaks down T4 to T3. And this one needs to be fixed here too for reference. So this one goes from T4 to T3. And in this leothyronine is essentially just T3. So in the process, when you look at the thyroid hormone itself, or the thyroid stimulatory hormone, when your TSH is high, and I've encountered some patients who don't understand how to read these lab reports when it comes to thyroid. So, when you're consulting or counseling these patients, it's important to just notate some of these or help them understand some of these reports for them. When the TSH is high, your T4 or T3 is going to essentially be low. So your thyroid levels are going to be low. When your TSH is low, T4, T3 is going to be high. It's always going to be opposite. Um, so just keep that in mind. The TSH is the thyroid stimulatory hormone. So whenever there is low thyroid in the bloodstream, um, it's essentially going to ask for more. It's going to essentially try to increase its stimulation for more thyroid hormones to be produced. So that's why when you see the TSH is high, that means it's a signal that there must be low thyroid in the system. So therefore, that's why you would see a lab report showing low T4, low T3 in the labs. Um, that's pretty much it here. So just keep that in mind. And this is a mechanism of the adrenal, or not adrenal, but the adrenal gland, the pituitary hormone. So whenever the hypothalamus is gets a signal that there is low cortisol inside the blood, it's going to release a corticotropin releasing hormone, which is CRH. Then the pituitary gland gets a signal and it releases the adrenocorticotropic hormone. After that, adrenal cortex or the adrenal gland converts cholesterol through some mechanistic enzymes to cortisol, and cortisol will basically enter the bloodstream and provide negative feedback to hypothalamus. So um, cortisol essentially, again, you would see that a lot, especially when you're dealing with like energy production and all of that. So it's important to have a sufficient amount of cortisol in the blood. But when it gets too low, then the brain starts to send signal to different hormones until it gets to the part where cortisol is being produced and entering the bloodstream and working its way to the target tissues. So a patient with primary adrenal insufficiency, Addison disease, requires glucocorticoid replacement. Which medication is most appropriate? So I've listed out some small mechanisms here of how some of these medications work. Ketoconazole, there's metyrapone, the hydrocortisone, pasireotide. Now, the ketoconazole is an antifungal medication mainly. However, when taken at higher doses, it can help with some of the overactivity in cortisol production. So it will basically inhibit the CYP450 enzyme that's used as metabolic stimulation of, production of cortisol. So when inhibiting this metabolite or this metabolic enzyme CYP450, it's going to also inhibit the cortisol synthesis. Metyrapone, similarly, it inhibits the CYP11B1, which is the 11 beta hydroxylase, also decreases cortisol. And hydrocortisone, this one works where it binds to the glucocorticoid receptor inside the cell, and then it binds to the glucocorticoid receptor DNA structure, where it kind of programs it so it can produce more cortisol. And pasireotide binds to the SSTRs, which is a somatostatin receptors, and basically it's going to halt the adrenal corticotropic hormone production, and so there'll be less cortisol produced in overall in this. Now, it's important to understand the differences between Addison disease and Cushing disease. Sometimes you might be confused between these two. Cushing's is basically when a patient um, has lots of cortisol inside the blood, and then we need some way to reduce that, and there's an overactive amount of cortisol. So to treat this disease, we need to use medications to decrease the cortisol amount. So things like ketoconazole, etiropone, pasireotide. Addison is where there is not much cortisol in the blood. Needs to be added. So hence the word Addison. So just having more cortisol to treat that disease of the primary adrenal insufficiency. So hence the answer for this is going to be hydrocortisone. The next one is dealing with osteoporosis. A 70-year-old postmenopausal woman with osteoporosis requires first-line pharmacology treatment. Which medication is most appropriate? Calcitonin, alendronate, prednisone, or teriparatide. Now, most of the time, when it's postmenopause or after menopause and then not much estrogen being produced, it might eventually lead to more so to osteoporosis if not detected early. So it's definitely important to understand some of these medications work both ways, and they work to help in patients who have those symptoms where that might lead to osteoporosis, and those patients who don't have much calcium in their blood to mineralize the bone strength to prevent the osteoporosis. Or in other words, there's too much osteoclast activity. So osteoclast is essentially catastrophic. It's a way of breaking down the bone. And osteoblast is when the bone's being built. So calcitonin in this case is going to be one of the medications to help with continuation of bone production. It's going to bind to an osteoclast receptor and prevent its activity from functioning. Alendronate similarly, but alendronate is definitely embedded within the bone where the hydroxyapatite is located, and when osteoclast tries to take in that particular when it starts to take in that alendronate, it's going to deplete the function of the osteoclast activity. Prednisone, you've already heard, is like a steroid hormone like hydrocortisone. It works by binding to glucocorticoid receptor. Prednisone converts to prednisolone. Prednisolone is the active drug. Prednisone is the prodrug. So make sure you understand that. And then teriparatide, it just binds to the osteoblast and pretty much prevents that or works with the osteoblast in terms of its activity. Give me 1 second. So it basically helps to increase the osteoblast activity and number and decrease the cell death. So essentially it works to help with building of the bone. So in the to answer a question, when it comes to postmenopausal women with osteoporosis and you need first line treatment, it's going to be alendronate. I know some of these other medications can confuse, but alendronate is very common. They come in different strains, but the main strain you might see most patients taking are the 70 milligram once a week alendronate medication. And I think you could also see some patients also on alendronate 10 milligram, which is usually given like once daily. So, also note these different counseling points and how it's taken and all, and take note in the directions, the way this medication is taken. Unlike prednisone, calcitonin, which you would find as a refrigerated product, usually in the refrigerator, teriparatide, I haven't seen it much in practice, or maybe we have just not used it a lot, but it's sometimes used also for bone production and bone health overall. So it's important to have an idea as to how some of these medications work in case you're asked a question on the test about its mechanism. The next thing I'm going to talk about is the normal reproductive pathway. Hypothalamus basically releases the gonadotropic releasing hormone, GnRH, and then the anterior pituitary releases the FSH and LH, and FSH stimulates the follicle growth, and hence the name follicle stimulating hormone, and then the other one's luteinizing hormone, which triggers ovulation. And then finally, the ovary produces estrogen and the progesterone, and estrogen provides negative feedback to the hypothalamus and the pituitary. When it has enough already, it's not going to need anymore. It's going to signal it back to stop the production of more estrogen. And, when it comes to estrogen, this also plays part of a role, especially with patients having like breast cancer, those kinds of cancers that where there's estrogen, where there needs to be like estrogen blockers in place. But that's a different topic for another time. This one is just about the reproductive pathway. So this is about polycystic ovary syndrome, has regular menses and insulin resistance. Which medication improves insulin sensitivity? Well, I can tell you one thing. You probably already know the answer to this just by looking at the drugs here. But the four choices are clomiphene, letrozole, metformin, or finasteride. The purpose of this discussion is not just to give you the question answer approach, but to show you mechanistically how these medications work as well. So in this case, if we look at clomiphene, it's mechanistically, it mainly works basically around the hypothalamus area. It's going to bind to a receptor, and then ovulation will occur. Letrozole is going to bind and prevent aromatase, so the androgens doesn't get converted to estrogen. And then the metformin is one that you would see in diabetes mainly, um, is one where it will bind to AMPK, and it's going to decrease the production of gluconeogenesis, or production of glucose going to the blood. So that's essentially that. And then finasteride will basically inhibit the enzyme 5-alpha reductase, which is used to convert dihydrotestosterone to androgens. So there will be less androgens produced here. So essentially, that's what's happening here. Now, the question is asking which medication improves insulin sensitivity. Well, so far, none of these other medications except for metformin is the one that will improve insulin sensitivity, especially since there's not overwhelmingly amount of glucose in the blood, so it will decrease the gluconeogenesis production, and then there will be insulin secretion that way, or increase insulin sensitivity in various types of tissues in the blood. So the next one deals with menopause. A 53-year-old woman experiences moderate to severe vasomotor symptoms. Um, she has no history of breast cancer or thromboembolic disease. Which therapy is most effective? So you would see that there are four choices here: calcium carbonate, estrogen therapy, alendronate, levothyroxine. Of course, you already know the two mechanisms here, the alendronate and levothyroxine, just in general. Calcium carbonate is kind of very similar to someone taking Tums, for example, when they have heartburn or something like that. Um, but in this case, calcium carbonate can also be used to help with mineralizing bone. So whenever it's taken, the stomach acid will break down the calcium carbonate and just have calcium. And the calcium is going to be absorbed by the bone and mineralize that bone overall, strengthening it. The estrogen therapy after menopause, there will be normally after menopause there will be decreased estrogen, and then there will be more wrinkle and less osteoprotein, and that fine would lead to more of a that as an end result would possibly lead to more of osteoporosis. So with this medication, it will bind to the wrinkle and increase the OPG, and then decrease the osteoclast activity. And the alendronate, you already know, you have some idea what the mechanism is there. Levothyroxine, which has absolutely nothing to do with menopause at all, or any of the reproduction at all. So, and the alendronate may have some, use in terms of this, but when you look at the answer choices here, it's always important to know what is what they're looking for. So the most effective therapy in this case is going to be the estrogen therapy. So that would be answer B. And then the last one, it deals with obesity. A 42-year-old patient with obesity and type 2 diabetes desires weight loss. Which medication promotes weight loss by activating GLP-1 receptors? So we talked about glyburide, we talked about pioglitazone, insulin glargine. The only one I haven't talked about with you is the semaglutide. Now, something like Ozempic, I'm sure some of you have probably heard. There's a medication there's a new type of formulation that's coming out. It's the Ozempic pills. You've also seen the Rybelsus, is another formation of semaglutide, but semaglutide mainly works in both the alpha and the beta cells of the pancreas. Alpha cells, they essentially are used to um, increase the glucagon production, so increasing that glucose production in beta cells to decrease insulin secretion. So in this case, it will do the opposite. It's going to bind to the alpha cells and the beta cells, so it can decrease the glucagon and increase insulin secretion. So the answer is going to be semaglutide. Because I'm sure some of you have heard that, in the past that Ozempic was being used also a lot for weight loss as well. And now people are considering more toward the Zepbound, Wegovy, there's Monjaro, but even those, it's shown to be indicating more so with diabetes. Some people still consider weight loss, so in a way it may help. However, its main purpose is to help reduce blood sugar. And that's pretty much it. And if anyone has any questions or like to do or have any feedback or want to comment, feel free to let me know. This was just a short presentation. I'll have some more videos for you all to review when we get to them. So feel free to let us know if you have any other questions. And I'll see you in the next video. All right.